Okay, pheasant test. As a quick kind of caveat to this, what really works well, if you are trying to convince a patient that they have potential for segmental instability, and their role in being able to remedy that, I was telling you that story about the lacrosse player that I had that was able to control her back pain by recruiting her transverse abdominis. This is a great way to get the patient to buy in, and so I'll often do this with a patient. Patient's lying prone. Let me have you slide a little closer. And you're essentially just kind of taking their leg and you're flexing them. Now as I flex this leg, what I'm doing is I'm observing what's going on in their lumbar spine. If there is more segmental mobility in their lumbar spine than what's available in their hip flexors, then when you flex their leg, at some point, what's going to happen in their lumbar spine? Yeah, it'll actually increase their lordosis, right? So you may actually observe or palpate and observe that when you do this, their hip flexors are so tight, it's recruiting their pelvis, and that subsequently is causing their lumbar spine to go in a bit of increased lordosis. What's really nice is if you do that and they report to you, oh, that hurts, and that's the pain that brought them in, you immediately have a fan. You immediately have gotten this patient to buy in, because what you're going to convey to them is that the most mobile segment in this chain of multiple segments, i.e. the bungee cord scenario, is the lumbar spine. So if they don't have enough mobility or flexibility in the hip, the lumbar spine is contributing to that. So now I talk to them about running upstairs. So imagine going up a stair and not having this amount of hip extension. What's going to kick in? Well, your lumbar spine, right? You're going to be cheating using your lumbar spine all the time. So you're going to get low back pain. This is the weakest, most mobile link in this chain. So once you get them to buy into that, and they have pain with that, and it's their pain, you then teach them the transverse abdominis. You have them engage that transverse abdominis while you palpate, and you notice when you flex their knee, what happens to the amount of motion that's available compared to what they had a second ago? More or less. So I'm flexing and they have symptoms. Now I say, okay, go ahead and recruit your transverse abdominis, and now I notice I can't go as far, right? Because he's not cheating here anymore. I've taken out this factor. So now what I'm seeing is the true amount of motion that's available in his hip and his hip flexors. But what happens furthermore that's most profound here is when he engages that muscle and there's less motion here, his pain now is gone. And that scenario happens a lot with patients. I'll bring them through that process. They're prone, I'll flex them. Does that bother? Oh yeah, that hurts. And I see their lumbar spine moving like crazy. I'll come back to it. I'll have them learn the lumbar, the transverse abdominis drawing in. I'll engage them again. There'll be less motion, but that's okay because their pain now is controlled. So now they've identified a way to control the pain that brought them in. The pheasant test is basically going through that process. I bring them through, I look at what's going on here, and then if that's not producing their symptoms, what do we always do? Give them a little extra pressure. So I'm just going to give them a little bit of overpressure, which is essentially a central anterior glide, okay? And I'm looking at trying to elicit a symptom by identifying potential for segmental instability. I'll come back to that then with their transverse abdominis engaged, and they'll tell me that it doesn't hurt anymore. So we've kind of really come up with something that's real for the patient, and we've gotten them to buy into what it is that we're trying to accomplish. So that's the pheasant test and how we might think about that clinically and use that clinically.